Continue on with the next. I mean, you talked about Alzheimer's in MedSearch 1 or maybe fundamentals. So Alzheimer's is the most common type of dementia. Dementia is the general umbrella term for neurodegenerative disorders. So the most common form is Alzheimer's disease. So this is a progressive, chronic deterioration of the brain. Literally is shrinking here. Life expectancy is quite long. I mean, it has a big range. Some people live a long time. It really depends on the care that they receive. So imagine someone with a deteriorating brain function, meaning they will be unable to do the most basic of tasks. The patient becomes a shell of the former self. So the mind here fails. The body is still good. But of course, unless this mind can take care of this body, then the body will also decline. So like I said, the life expectancy varies depending on the care that these patients receive. If given the proper care, these people can still outlive their caregivers, meaning the caregivers might die sooner because of the exhaustion from caring of these people, based on my experience. Some people deteriorate quite fast, and especially those that do not get care or are even neglected. So they can easily lose weight because like I said, the most basic of function is gone. As simple as eating, for instance, they do not remember when to eat or how to feed themselves, depending on the stage of the disease. So unless they're fed, they will not eat. They will have no desire to eat, or they will not know that they need to eat. All right. So it's a sad disorder. We've seen people, let's say they were teachers, they're grandparents, they are managers, they are scientists, and then when they hit with this disease, that's it. They become uh, just um, um, a human being. No longer functioning mental wise. They're unable to do the things they used to. And the sad thing is they don't even recognize their own family members anymore. Yes.
So they died from the lack of care itself, not even Alzheimer's disease itself.
Yep. It's really from the inability to feed themselves.
Okay.
So unless some of these patients, unless they have a living will, let's say, because if you once you put a feeding tube in these patients, they can have an indefinite life. They can go 100 years old because now you have a feeding tube. So as long as they're fed each and every time and maintain that feeding tube, meaning no complications, no infection, no aspiration, yeah, they're good to go. Most people, though, that have become aware of feeding tubes, remember the story, the real story of Terry Schiavo down in Florida? That young woman in her
Yes.
early 40s. Yeah, it became a nationwide sensation. The case went to court, and even the Pope chimed in on it. Gave Pope John Paul, I remember, gave a piece of his mind regarding the case. Anyway, the case was about a woman who was in a permanent vegetative state. She had a feeding tube, so now her life is going to be indefinite. The husband insisted, in the absence of a living will, that his spouse, his wife, told him verbally that she did not want any of this. So, of course, she was married legally. So the court decided that the husband was, the patient's, the patient was the ward of the husband, not the state. And it was a big, bitter legal fight because, of course, the parents wanted her to keep the feeding tube. But the husband decided, and ultimately the court, you know, honored, that decided that the husband's, has legal guardianship over her, and he decided to have the feeding tube pulled, and then she died soon after. So after that, many people became more aware of what feeding tubes can do. All right, and then do they really want that kind of life? That you're just there, that people feed you, and you can live forever, but then you're not there mentally. All right, so it steered awareness about, do you really want that, or do you want to go? However, it depends on your spirituality, your religion. In the case of me as a Catholic, now, the Pope did say that extraordinary means, extraordinary measures can be declined. Meaning, you can say you want to be DNR because technically your life ended, right? Naturally, your heart stopped, you died. So having CPR done, chest compressions and all that, because these are all now extraordinary means, right, to prolong your life. So you can refuse that. The Pope did decide that nutrition, however artificial, is a basic need, so therefore is not extraordinary. So I kind of, because my living will really says I don't want artificial nutrition. But anyway, that's me. But so and then I'll live with that. Um, okay. So what happens here is there is on autopsy, these patients' brains weigh less than a normal brain. So it literally shrinks over time. And we don't really know the cause. They find these fibers, these plaques, neuritic plaques, dying and dead nerve cells. So they find these in autopsy, and proves that you can take an MRI of a patient, and if you see these plaques, then you can make a diagnosis of Alzheimer or dementia, or Alzheimer's disease in this instance. So literally your brain shrunk. It deteriorated, that's why it accounts for the loss of function. There are different stages. The earliest signs is this one, forgetfulness. This is beyond the forgetfulness that you and I um, experience every now and then. This is like forgetting familiar places, like you don't know how to get home, for instance, or I mean, most of us misplace our keys, right? But these guys will, the misplacing the keys thing is like an everyday thing now. So short-term memory is a problem. Long-term memory, though, is intact. There's agnosia now, meaning you give them an object, they wouldn't know what to use it, what to do with it. For instance, you give them a spoon, right? You give them a meal tray, and then a spoon or a fork and a knife. They wouldn't know what to do with it. That's agnosia. So previously, of course, they know how to use that object. You give them a hairbrush. They wouldn't know how to do with it, what to do with that hairbrush. Okay, that's agnosia. So as the disease progresses, there's a loss in ability to perform multiple or complex tasks. So now they start having problems with financing. They can't balance their checks, or what to do with budget, and besides misplacing things, now they can get lost. They have affect personality, and there will be a loss in social skills, changes in personality, and can even have aggressive or uncontrollable acting out behavior. So this can come unpredictably in social situations and can lead to embarrassment for the significant others, leading to them being removed from the situation. So as the disease uh, goes on, self-care is now gone. Um, so basic toileting, feeding themselves. So this is what I was saying, that unless they have a good caregiver, they can die because they can't take care of themselves anymore. They can't feed themselves, much less do anything else. So they will lose weight, um, get malnourished, get pneumonia, because now they'll keep staying in bed, malnourished, dehydrated, and die. Yep.
So, working in EMS, I've dealt with a lot of Alzheimer's patients and dementia patients. A lot of my calls for them are for dislodged feeding tubes because they continuously pull them out. What do we do with them? We can't tie them down to stop.
Yeah, we our what can you hear Nicole's question?
Can you repeat that?
She's asking that in her job she gets frequent calls for um,
Dislodged feeding tubes.
yeah, dementia patients pulling out their feeding tubes. Um, and what was your question again? Oh, to prevent that.
Yeah, what do we do with them?
Okay. Not really much because now facilities are restraint free. So you can't really prevent them. You can't tie them down
They've
anymore.
gotten so to the point in facilities you can't even put up side rails because they count that.
Yeah. Well, 4 side rails. No 4 side rails. We can still put up 2 or 3. What we've done in the facility I worked for was put an abdominal binder to hide the tube. So meaning out of sight, out of mind. I mean, basically that's all you can do because again, we're restraint-free facilities now.
Could you, I mean, I know it's gonna sound horrendous, could you give them like medications and maybe like mellow them?
We do give either phenobarbitals, um, other benzos, but I mean, it results in the patient being sedated and now they won't eat because they're sleeping. So we try to avoid it also because not all of them have feeding tubes. Plus, I mean, when they're in bed most of the day, now you get problems with DVT, pneumonia, UTI. So we really try to stay away from that. It's more trouble than it's worth. So we invest in sitters, basically. Yep, one-to-ones. That's why this is a high cost. I mean, it's gonna drain Medicare, Medicaid funds. I mean, they require 24-hour care. Plus, they don't have, you can't predict when they sleep. I mean, they have no concept of day and night at a certain stage. You know about the sundowning, right? They can't tell, is this sunset or is this sunrise? Yeah, so they can't, you know, they can't tell. So sleep disturbances are common, which strains the caregivers. Because imagine having to stay up at night watching them. Um, I can relate. I had a grandma on my maternal side that had this. You know, it was, she treats us as strangers. She's very polite. Picks you up. Hi, excuse me. Can you show me how to get out of this place? You know, she doesn't recognize us anymore. And she says, you know, I'd like to go home to see my daughter, and she's speaking to her daughter, to my mom. Other complications come from this, of course, decreased mobility, Will lead to possible DVT, stroke, all kinds of problems. Let's go now to treatment. So the mainstay is MMDAs. We have Namenda and um, what's the other one? There are two main drugs here. The other drugs are to treat symptoms only. But as far as the medications, there's no cure for Alzheimer's, but we do have medications to slow down the progression. Like I said, it's Namenda, which is memantine, and starts with a D. Let me look it up.
They don't have the name in the book.
I don't see it. Okay, memantine and Aricept. Okay, there, Aricept. Aricept is what's the generic name for donepezil? D. Yeah, D. I knew it was D. All right. So these are the two drugs. They can be separate, or some patients are put on both or for dementia. Neither drug, donepezil. I don't think it's here. Oh, right here. Sorry. All right, never mind. It's table 36.8. We have donepezil or Aricept and Namenda. Those are the only two I'm testing. Memantine and donepezil. All right. So usual, these are drugs. So testable parts are nursing responsibilities. So that would be side effects.
So none of these drugs, there's no way of slowing the progression.
No, this again, these are given to slow down the progression.
But that one says does not slow.
Um, okay, this one is used for that purpose. However, again, even though it says here does not slow, it does help maintain the memory. Um, at least the patient still is stimulated. But again, neither drug will stop the course of the disease. You can only maximize their function, but it's inevitable. They're going to deteriorate and they will eventually become bedridden, and meaning no basic function now. They will just sit down and do nothing. All right, so I already mentioned there's no cure for this. You can only keep them around. So I really encourage people to have advanced directives. You know, what do you want? Because you don't know, you develop this, then when you have this, then you can't sign a living will anymore. You can't put it down. So have them now while you're still able to.
Yeah, they become very selfish at a point when the patients
Right, because you know what your family will do.
keep you alive until they like shrivel to death.
Yep.
It's so sad.
So if you don't want that kind of life, then put it in writing. Plus, my main concern really is my family. What are they going to do with their lives? You know, just take care of me. You know, I'll be, yeah, I mean, they should.
Miserable though. They leave their loved one with Alzheimer's or dementia in the nursing home.
Yeah, that's even worse.
They don't come back for them. They live their lives and refuse to sign a DNR, DNI for them. Just let them go
Yeah,
out.
exactly.
It's horrible.
Because, I mean, I don't blame them, you know. I mean, they have their lives to live. I don't want to be a burden on anybody. Yeah, it's my problem. So this is not your problem. Okay, and here's your nursing care. Please read on your own. Again, maintain safety. One last thing is the family. Like I said, the caregivers here bear most of the burden. The patient is not aware at all. So the family do need respite care. So make sure the family gets a break. No, 1 to 2 days, that's a lot already. That will count, that will go a long way. Make sure, because most of these patients, especially spouses, are so devoted that they will literally kill themselves taking care of these patients. That's not good. So they have to understand that respite is for them. No, they need a mental break. They need to be physically away from these patients and tell them, that make them realize that, you don't have to be guilty about this. Because if you don't take care of themselves, who's going to take care of this patient now? So you have to take care of yourself too, because when you're gone, this patient will follow. Who else is going to take care of them? Any question? Alrighty,
Question.
let's
If a
proceed.
patient already diagnosed and refuse medication or repeat treatment, do you obey what they orally say to you?
Sorry again, Yan. The audio is very poor. You
Um,
said something about medication.
they diagnosed time and they refuse test the medication and treatment. Do you listen?
I'm sorry.
Yes.
Can you put in the chat? Can you? Hello, Yan. Are you ready?
You know, Alzheimer's patients are like all these kind of patients for that exactly.
Okay. Good question. The question is, if they refuse medications, do you listen to their request? Literally, technically, even though they have cognitive decline and they are therefore incompetent, when you can't really force medications down them, that will still be assault and battery. So if you can't, then we can't give the medication unless, of course, the doctor insists and it will be given parenterally, by injection or IV. But no, that still constitutes assault. And plus, you can cause injury if you force it down, especially if there's no feeding tube, you force it down the throat. It's not safe either. So, no. Did that answer your question? Let's say in the hospital and then you have medications ordered, right? And they refuse. Yeah, you can't shove it down the throat. You have to just, document that despite efforts to, let's say, we try our best, to crush, if we can crush the pill and then give it through with ice cream or applesauce, for instance, we can do that. Um, yeah, but then the moment they taste the medication, you didn't mix it very well, they'll spit it out. But basically, it's just not safe. So no, it's not worth it. If the doctor really insists, then he can order um, a different form. Or if these patients have a feeding tube, that'll be the safest. Any question on? Okay, let's proceed with MS now, and we'll end with spinal cord injury today. Page is We're at 760. Okay, 7. Where did we end? 7. Okay, so this is the Alzheimer's. Okay. Um, let's go to 777. MS. So this one is a demyelination problem, still a chronic neurologic disorder. Autoimmune again, no known cause, or we have some risk factors, but we really don't know why. Autoimmune because literally there's autoantibodies here. So the patient develops autoantibodies against your myelin. Now, myelin is found on the surface of our neurons. Not all of the myelin is attacked. So there will be patches of these. So let's say this pen here is a neuron. So it will be patchy areas wherein there's insulation here, none here, insulation here, none here. So there will be patches of these destroyed myelin sheets. Again, the patient has autoantibodies against the myelin sheet, leading to demyelination. Because we need the myelin sheet for a smooth transmission of signals on our skeletal muscles for movement, because these areas are not smooth anymore because you have areas that are destroyed, then the patient will have tremors. That's not the, I'm not testing the types, by the way, so you can just disregard that. These are your, oh no, that's HNP. Okay, so here is your clinical manifestations for MS. Once myelin is destroyed, then there'll be sensory, motor, and some thinking problems because these will affect all neurons, not just on your skeletal muscles, but also in your brain. So there will be numbness or weakness in one or more limbs, vision problems, double vision, tingling, there's pain, electric shock types of pains, tremor. This time the tremor here is intention tremors, unlike in Parkinson's wherein it was resting tremors. This one, when they move, they have the tremors. The pain can be debilitating. The pain can be usually in the joints or in the muscles. Most people will be disabled. They will be unable to work, although in the early stages of the disease, or if the disease is well managed with medications, they can work. But definitely when they have exacerbations, they cannot function. They'll be bedbound. Yes.
Because of how it's manifested in the joints and stuff, would you give them like an anti-inflammatory, or would you give them more something like that?
Okay, the treatment here would be similar to rheumatoid arthritis. Okay. Yeah, we'll get to the treatments shortly. I mean, all autoimmune diseases have similarities in their drug therapy. As far as diagnosis, it's not the easiest one to diagnose. There is no specific test for it. Meaning you can't just order one blood test that will tell you, oh, this is MS, you're positive for this. No. They resemble other disorders. Patients will have some arthritis, rheumatoid arthritis symptoms, some other connective tissue disorder symptoms. It's not easy because they're not specific to MS. They are common in most other autoimmune disorders. So clinical symptoms are basically the basis here. And of course, we'll do other tests in order to rule out the other causes. So that's the purpose of the testing here is more to rule out other causes. That way we can we can arrive at a MS diagnosis. Same as Parkinson's or any other autoimmune disorder, no cure. You can only control it with lifestyle management and medications. So we have rest, exercise, stress relief, because these are all your triggers for an exacerbation. So our goal here is to keep the patient in remission. So as long as they take these medications, avoid stress, eat healthy, exercise regularly, they should be fine. They can live a relatively normal life, same life expectancy as well. Look at the signs and symptoms. So it starts from your CNS all the way down to your bladder. These patients will have bowel and bladder problems, as well as sexual dysfunction as well. It's important because look at the age range that are affected. We had it here, right? Under incidence. Yeah, 20 and 50 years old. It's quite young. So as young as 20, for instance, or 50, either way you look at it, these are productive people. They are in their productive years. So they are working individuals. They are professionals, could be nurses. So it's not that easy. Look at the resulting interventions. Again, why is this here? Oh, never mind. So here are your problems associated with it. Let's go straight to management. There are maintenance drugs to keep them in remission. However, there will be unavoidable periods of exacerbation wherein they will be hospitalized, just like lupus. To keep them in remission, of course, these are autoimmune disorders, so therefore we will suppress the cytokines, the parts of the immune system that cause the symptoms, particularly interferons. We have beta and alpha interferons here. We have glatiramer, which is subcutaneous injections. This is PO, fingolimod, and natalizumab, and mitoxantrone. These are immunomodulators. So again, the problem is an autoimmune caused by antibodies. So therefore, we will interrupt the body's ability to produce these antibodies by targeting our interferons and these immunomodulators here, glatiramer and fingolimod, and this one here. These are, again, I like to emphasize, these are going to be your maintenance medications. These are day-to-day medications. Their intention is to slow down the progression, and then once they have exacerbations or attacks or flare-ups triggered again by the high, high temperatures, high stress periods. Those are your triggers for a flare-up. When they are hospitalized for that, they will be put on high-dose steroids because these drugs previously mentioned here are not going to work anymore. So to do big-time suppression of the immune system, they will be put on IV steroids and even plasmapheresis. You still remember plasmapheresis, correct? This is plasma exchange. Yeah, because where is the antibodies located? In the plasma. So that will be your treatments, short-term treatments during exacerbations. Yes.
With like plasmapheresis, is it like the same thing as like before, where you need like a certain amount of treatments, like each week, and
Yeah, so it'll be a few weeks, right? So a few treatments each week for 2 to 4 weeks, depending on the symptoms.
This is kind of like comparable to like lupus in some ways. Is it comparable?
Yeah, they're all the same. I
Is it
mean,
comparable to the
autoimmune.
fact that they would need like
This one doesn't affect kidneys, if that's what you're asking. This one doesn't affect kidneys. If
no,
that.
I'm talking about all organs in general.
No, not lupus is worse. Lupus is systemic. This one is more CNS and muscles. Speaking of muscles, because of the tremors, and then they'll have problems with bowel and bladder here, plus they'll have muscle spasms, so we'll give them muscle relaxants for the spasticity, which can be painful. With regards to bowel and bladder problems, we just do, because they can be either incontinent or sometimes they'll have problems peeing, or they can get constipated in some instances. So here's a summary of your drug treatment, table 37.4. Again, they're all immunomodulators. So interferons, glatiramer, I already mentioned this is PO. Where's Copaxone?
It was with the pinball point.
I'm looking for,
It's right there on top,
Copaxone, sorry. Okay, here, glatiramer. This is injectable. This all of these here, the first three, interferons and glatiramer, are subcutaneous. These are pre-filled injections like Lovenox. Patient, of course, administers that themselves. And here we have PO now. So these are the common ones. For bladder, to slow down the bladder leaks, because again, these are 20 to 50. That's a problem, right? When you get incontinent at that age. So we'll give them um, ditropan, which are anticholinergics, to help with the overactive bladder kind of symptoms.
Which ones are given during a flare-up?
For flare-up, it's basically steroids and plasmapheresis. But all of these other drugs are your maintenance, day to day. This one, I'm not saying they have steroids, but these are used for pain as well as basically it's for the pain, because these are neuropathic type of pain. Here, for like I said, they can have two problems here, either incontinence or either urinary bladder retention or bowel impaction, constipation. They either have stool softeners and laxatives. Okay. Antimuscarinics have the same effects as anticholinergics, so don't get confused. They're basically similar. Anticholinergic means antimuscarinics also. Yeah, they're basically the opposite of parasympathetic, because when we say parasympathetic, always think about rest and digest. Whereas when you say anticholinergic or muscarinic, that means we're mimicking sympathetic. So because when you're eating and digesting, resting, what happens to your heart rate? Low. What happens to your smooth muscles? And they move, right? So you digest, so it increases peristalsis. Um, and of course, you don't need any bronchoconstriction, so there will be bronchodilation, right? I know. Also, actually, it's the opposite, because you don't really need to be breathing. Yeah, you'll have bronchoconstriction. That's why these are the effects of parasympathetics, meaning your drugs that will suppress the parasympathetic responses.
All these drugs are going to be
Yes.
When you say anti-muscarinic, that's the same thing as muscle relaxant, right?
This one with similar to anticholinergic, same effects. Here, reduces bladder spasms by inhibiting acetylcholine. This one also inhibits parasympathetic system. So basically, this one has same effect as sympathetic. That's why when you give tiotropium, which are anticholinergics, they have the high heart rate as a side effect. Here are your complications of MS over time. They will have these. In severe cases, it can lead to paralysis. And then eventually permanent bowel and bladder issues and sexual function. Again, these are 20 to 50 years of age. So they are sexually active.
So you wouldn't find like a 7-year-old that would all of a sudden develop?
I've not seen any or heard case. It could be. I mean, there's always, these fluke cases, but typically it's between 20 and 50. Because it's such a young age, on top of these problems, they do have psychosocial issues. Now we got depression, um, plus the disease itself involves the CNS, so there'll be some thinking problems, cognitive issues, memory loss. So this is what I mean by it can cause disability.
Um, so like I've obviously seen people that like gotten MS and then like they've been in the recovery and like they've done PT and they were able to like walk again and do whatever they have to. What is like the likelihood that it can happen again? Like
again, there's no cure for this one. You can only put them in relapse in remission, but there's no cure for MS. Some cases who say they were cured, they probably didn't have MS. It was probably something else. They were just misdiagnosed, most probably.
How often do they stay? Like, how long do they stay in remission?
Oh, actually, as long as they don't have a really stressful job or stressful life, they function pretty well. Yeah, I've seen some even get pregnant and carry them to term also.
That's crazy. Isn't pregnancy like crazy stressful on the body?
What?
Isn't pregnancy like really stressful on the body?
Oh, they just do a lot of yoga and stuff. I mean, if there's a will, there's a way.
But they obviously couldn't have a natural birth. They would have to have C-section.
They do. Some of them go into labor. Yeah, some. Probably easier to have a C-section.
Yeah. That would, could you imagine like having a flare up like while you're pushing your child out?
it wouldn't happen that quick.
What will happen?
Like if you get like a flare up like while you're like giving birth.
I know it will develop, of course, just like any other, slowly over a few days. Here are your teachings. Definitely all testable. Questions on MS? Very good. Go to ALS. This one is sad. The other term here is Lou Gehrig's disease, named after Lou Gehrig, who got the disease. He was a baseball player, right? Like Babe Ruth.
No.
I think so.
I'll look it up.
I think that's who Lou Gehrig was.
Yeah.
Okay. Anyway, this is a lateral sclerosis that's in the lower motor neurons, causing muscle weakness and atrophy. Since it's lower motor neuron, the brain is not really the cognitive function is not affected. So they're smart, they're as sharp as ever until the day they die. Their mental state is intact. It's just that because it affects the lower motor neurons, it affects the ability to walk, and then eventually the diaphragm will fail, and that will cause their demise. From the time of diagnosis, the expected life expectancy is about 3 to 5 years. Just like MS, you can, at least MS, you can live a relatively normal life expectancy. These guys, though, no. They die, like I said, within 3 to 5 years of symptom onset, and they will be put on a ventilator. and then for just survive for as long as they can. Once diagnosed, they pretty much have a death sentence. So they spend that time with family because that's all the time they literally have left. Um, our treatment here is just going to be prolonging as long as possible, and we want to delay mechanical ventilation. So keep them as active as possible, maintain muscle function because it will, once there is no more innervation to the muscles, they become paralyzed. And of course, that muscle, once paralyzed, will atrophy. Very little percentage is caused by a genetic defect. For the remaining 90%, we have no idea what causes this thing.
So would you set these people up with like hospice care as soon as they get diagnosed?
Well, not necessarily, because they can still walk, right? They can still walk. They'll go from walking to a cane to crutches to a wheelchair, and then bedbound on a ventilator. So it's progressive deterioration. The motor neurons eventually die, and then therefore no more muscle control. It will eventually again affect the diaphragm, at which point then they will be intubated. Unless they have living will already set up that they don't want to be, then so be it, whatever they want. Um, so this sad disorder is predictable. You can see literally the sequence, the pattern of progression, and the patient and the family are aware of what's gonna happen. So they just basically spend their last days, last years just enjoying, right? Because they know what's gonna happen eventually. Meanwhile, to because our goal again is to prolong the life as much as possible, to delay the mechanical ventilation, so keep them as active as possible, so keep them safe. So it also affects the bulbar muscles as well. The bulbar muscles are those involved in talking, chewing, swallowing. So institute um, aspiration precautions. They'll have dysphagia. Medications, not much we can do. With testing, look at this. Same as MS, it's not easy to diagnose. We do test all of these just to rule out other causes. Same as the story you said was MS, that there are stories that they do recover. I've also seen a special on CNN. Farid Zakaria, right? He has these nice stories. So he featured a doctor in Europe who claimed he cured ALS. He had 10 patients from different parts of the world, but because there was no independent examination of his patients, so we really had no idea whether or not they really had ALS. But based on the documentaries, the videos he had, they did look like they had ALS. But like I said, it didn't really go anywhere. Um, Plus, that was all his sample was the 10 patients. They were all. I mean, I'm happy for those patients because they were cured. But I'm skeptical. I don't think they were actually ALS, because why are all the other ALS patients dead?
But just your 10.
Yeah. And his treatment was really unconventional. He didn't use medications at all. If anything, there was supplements. There were no drugs involved. He just eliminated all artificial, meaning everything these patients ate and drank were from nature. like no nothing processed. They ate, all vegetables, literally coming from the ground. No meats either. So they were allowed tofu and stuff, but really straight vegan, I guess. Um, and that's all he did. Um, and supplements, vitamins.
I know, like it says, like there's like a B12 and E deficiency. Like, so why don't we like supplement that like for like MS too? Because they're
I
also
mean,
deficient. It
it,
doesn't
it
matter.
probably, yeah, it probably wouldn't hurt, but there's really no evidence that it makes a difference. But whatever, keeps the patient motivated, yeah, give them those supplements. There's one drug used here, but again, no cure. This drug is just going to slow the disease progression, delays ventilator support. It delays their having to be intubated. The drug is highly hepatotoxic though, so watch the liver while they're on this. Patients are made aware of that side effect, but at that point they'll just say hell with it because they're gonna die anyway, so they'll take it if it's gonna prolong their life. And the others are all symptomatic because of the low motor function, then they'll have constipation, bladder problems. So here, and then some muscle spasms, cramps. So we give them muscle relaxants like baclofen, then laxatives, stool softeners. Basically symptomatic, except for this drug here again. It's the only one that,
It's like a maintenance drug for it.
yeah, it's the only one FDA approved for just to slow it down, prolong intubation, or delay rather, sorry, delay intubation. And the rest are supportive therapies like physical, speech, OT, and nutrition. Complications all related to immobility, pneumonia, DVTs, PE, MI, stroke. Here are again the supportive treatments except for number one. So that's riluzole. That's the only one that can delay it. If you look at the rest of them, they're all symptomatic treatment. So they develop depression, so you give them. Um, okay, I just realized I said to you guys earlier for one of the drugs used for Parkinson's, I said amitriptyline. No, I meant amantadine. I just realized it because amitriptyline is an antidepressant. Sorry, amantadine. Yeah, has a antiviral properties. Amantadine, it's an antiviral used for um, Parkinson's. Sorry about that. Amitriptyline is a antidepressant, Elavil. And here are your nursing management. Sorry. Never mind. That drug wasn't in your in your textbook anyway.
Oh yeah, it's like I said,
Okay. So mostly supportive, like I said earlier. So support the family. They will have grieving, anticipatory grieving in these patients. Okay, I'll just drag this for as long as this battery will take me. All right, this is the last part. Spinal cord injury. These are the causes. There are different levels here. So same as so far, we've done Parkinson's, MS, Alzheimer's, and then we did ALS. So this is another movement disorder. So sensory motor loss here is from literally injury to the spinal cord. As you know, all signals go up and down the spinal cord from the brain. So therefore, when the spinal cord is either severed or severely injured, so there will be loss of those signals, rendering your muscles and nerves useless because there is now no more stimulation. There's no movement. Patient becomes paralyzed. Unlike the heart, wherein the heart has action potential, skeletal muscles don't have that ability. Skeletal muscles need nerve stimulation in order to function. However, the spinal cord does not have to be severed, doesn't have to be cut for loss of sensory motor function. Major injury to it can result in the same thing. As far as signs and symptoms, I'm not testing incomplete and complete injuries. There are four of them. Yeah, four. You can disregard these incomplete injuries, so we'll skip that. I will test you on, there's a table here, right here, table 37.6, asking you what will be the patient's limitations. For instance, which minimum injury allows the patient to still drive a car? By driving a car, I mean with hand controls, because we do have vehicles that can be modified now that you don't need foot pedals. You don't need your foot to step on the brake or the gas. We have hand controls. They've been around since the 80s. How about this one? Because they have upper extremity function.
I would say yeah.
Yeah, here, they can have both flexion and extension.
Well, like, wouldn't they get more tired faster?
Unless they have myasthenia gravis, but no, I mean, they have full innervation to these muscles, so they can move.
Because I just see audibly do.
But they have, look, they have triceps, biceps, and wrist extension intact. So can they use their, and some use of the hand muscles. So can they touch and use? Yeah, they can use their hands and fingers. Yeah. So questions would be either what will be the limitations or what can they do? Okay, so that's from C1. And of course, the way I would study this is I would do the bare minimum and then go from there. Because of course, anything let's say for C4, then that means forget about it. Forget about all these.
So
You know what I mean?
the injury is the worse.
Yeah, the worst. Yeah. Anything below, anything innervated by those spinal nerves below that injury is non-existent.
C1 to C4 is that.
Well, not really, because let's say your diaphragm, the phrenic nerve, is innervated by
C1 to C3.
C3, C4 actually. It comes out between C3, C4, so that's why here C4, 3, 5. There's still possible phrenic nerve involvement, but definitely C1 to C4, yeah, the diaphragm is affected here. They don't have spontaneous respiration because the diaphragm cannot move. It can't, it's not innervated anymore. So however you remember this, either this table or this figure right here, figure 37.12, whatever works for you. No technology currently. We do have robotics to allow patient to walk, but they don't do anything to the spinal cord. They just help the patient move. Um, okay, let's go now to treatment. The patient after spinal cord injury have reduced sympathetic stimulation. That's why if you remember in neurogenic shock, the patients, due to severe parasympathetic response, went into severe vasodilation and therefore had blood pooling and therefore severely low blood pressure. So they don't have this anymore. As far as neurogenic shock is concerned, we already mentioned this in exam 1. So this was our interventions. We gave fluids, vasopressors, and inotropes. So neurogenic shock will be on the exam again for exam 3, since this is under spinal cord injury. So these are your vasopressors: dopamine, epinephrine, norepinephrine. Please take note for the steroids here. This is clear. Current guidelines no longer recommend use of steroids for spinal cord injury patients. There's really no evidence for that. As far as immobilization of the cervical area, patients will be put on, well, for first aid, of course, initially it will be a cervical collar, but that is only temporary. We do start moving these patients. So we will put them on a halo traction device. Here is the picture. That's a halo device. It's screwed to the skull. Obviously, the purpose is to stabilize the neck and the upper thoracic uh, vertebrae.
How would you care for the skin?
Okay, this would be the same as any other skeletal traction. Um, Remember external fixators in musculoskeletal system? When you have a fracture, and then instead of doing internal fixation, they'll do external. Um, Same thing. So you do pin site care using
Professor, we can't hear anything. Yeah, I think he said his surface is dying or something. Yeah, I think his iPad died or his tablet died. I think why.
Bummer.
Yeah, go ahead.
Well, it was working really hard today with that simulation.
Can you see my screen?
Yes.
Okay, sorry, the battery died. Okay, what was I saying? Okay, so this is an example of external fixation. So to stabilize the cervical and the thoracic spine, we use a halo device. The vest will be, sorry, I forgot about the two people in here. Okay, I'm still recording. All right, you can still see my screen, correct?
Yes.
Okay. So, okay, the Halo device is kept on for about 23 hours a day. We only take them off for hygiene purposes. Let's say the patient needs to change clothes, so that's the only time we take it off. How do we take it off? There will be a wrench behind it. We have a wrench taped to the back. That way, also for emergency purposes, let's say we need to do CPR on this patient, then we have the wrench handy because it's a special wrench to take off these rods. Okay, they will be kept in there in for emergency purposes. This one is a skeletal traction, usually done pre-op. No, just like any other pre-op patient for who had a fracture before surgery, before in this case before spinal decompression surgeries, we will do traction. So these are screwed onto the skull and then weights will be applied here. Obviously, this is over the bed, so it will keep the neck and the spine aligned. So this is a form of skeletal traction. This one is been specifically just for immobilization to keep the spine in alignment. This one is now traction. We'll talk about the nursing care for those pin sites shortly. All right, spinal shock is not the same as neurogenic shock. This is a complete but temporary loss of spinal reflexes, meaning sensory motor loss below the level of injury. This one, though, is, take note, temporary, meaning we may see initially that the patient has, of course, sensory motor loss, basically paralyzed. However, they heal, meaning this is not a permanent injury. How can we tell whether the patient has permanent injuries versus only spinal shock? We don't. The doctor doesn't know either, so we just wait. If the motor function, sensory motor function return, then the patient only experienced spinal shock. However, of course, if the CAT scan or the MRI of the spine shows a severed spinal cord injury, is it spinal shock? Of course not. These are the manifestations also. This part right here where it says there is anhidrosis, meaning below the level of injury there will be no sweating. All right, that's what it means, anhidrosis. We'll talk about this later when we get to autonomic dysreflexia, which is a complication of spinal cord injury. So that's the first complication here, spinal shock. Next one is neurogenic shock, which we discussed already in module 1, so I won't repeat that. Here's the other life-threatening complication. So the life-threatening complications here obviously are neurogenic shock and autonomic dysreflexia. Spinal shock is not really life-threatening. It's just scary because the patient, of course, thinks that they have a permanent paralysis. What is autonomic dysreflexia? This is a syndrome of massive imbalance reflex sympathetic discharge. This is occurring only in patients with T5 to T6 and above injuries, meaning this doesn't happen for lumbar injuries. Okay, so who are T5 and T6? So these are either quadriplegics, definitely, and some paraplegics as well, right? So T5, T6 or higher injuries develop autonomic dysreflexia. This does not occur during the acute episode, meaning when this patient first is admitted for spinal cord injury, this complication almost never occurs there. It often occurs after the first year of injury, meaning as parts of the spinal cord which were injured heals, um, and this patient experiences these triggers, namely, it's any strong sensory input, um, pain, basically sensations that you cannot ignore. For instance, pain. Can you ignore pain? Or you're in the train with a really full bladder. Can you take your mind off that full bladder? Or you're really constipated. No, you haven't had a bowel movement for a week. Can you ignore that sensation? No. Or and you have an infection or rapid temperature changes, or let's say, remember, these are paraplegics, right? What if they're sitting on their testicle?
Oh, no.
Yeah,
It,
but they can't feel it though because they are paraplegic, so they have no sensation waist down. But doesn't mean there is no sensation, no painful stimulus, right? I mean, they can't feel the pain, but doesn't mean it's not painful. Make
right.
sense? Yeah,
Yeah.
imagine sitting on your testicles. Another is, let's say you're wearing something tight in your legs, and again you can't feel it, so that's another noxious or painful stimulus. Wearing something tight, or let's say, oh, these patients are paraplegics, but they do have sexual activity still, meaning they can still have an erection, although the erection here is not on demand anymore. It's more from, I mean, they have to work really hard to get a an erection, meaning, massive, stimulation, stroking the penis, for instance, or doing, they have to work extra hard to get a reflex erection, because this is not on, like I said, they can't just think about it and then they get an erection. No more, because the spinal cord injury, um, um, made them lose that ability. So basically, all these triggers, again, add there the uh, sexual activity, or sexual intercourse, or a UTI, because these patients will be doing straight cat, so that's where the infection comes in. Here, this infection here is referring to a UTI. Pain can also come from, besides them sitting on the testicle, it could also be from a really serious pressure ulcer, because these patients will have pressure ulcers, high risk for them. So all of these sensations trigger a massive, um, here, sympathetic response, resulting in widespread vasoconstriction. The the curious thing about this is, instead of tachycardia, they will have bradycardia. So because of the widespread vasoconstriction, these patients will have a really bad hypertension. The blood pressure could be 200 up to 300 systolic millimeters of mercury. And there will be bradycardia. And then they'll have the sweating, um, the anhydrosis I mentioned earlier. So they'll have that. So here this explains, I don't have time to really discuss, let's read this. But basically what happens is they develop this hypertensive crisis with bradycardia, right here, severe headache, which is now a symptom of severe hypertension, bradycardia. Disregard this tachycardia because that doesn't happen. We have bradycardia instead, and there is diaphoresis, and here flushing above and pallor below the injury level, which is weird, right? You have parasympathetic in the top, that's why you have flushing, and then you have vasoconstriction below. That's why there is pallor. All right, so that's what it tells you here. This part here explains why that is. So please read that on your own. So there's sympathetic in one section and then parasympathetic in the other. That's why you have bradycardia and hypertension. So they can't be tachycardia at the same time. Make sense? So that's why I don't know why they put that there, because it's not gonna happen. Um, so the treatment here, because the whole operation was triggered by these stimuli right here. So therefore, if you eliminate the cause, this will stop. The most common cause is a full bladder or a full bowel. These are, I'd say 99%. These are the two causes. Between the two, it's more the bladder, which is good, because imagine what you have to do if it was the bowel. Can you imagine? Because you have to relieve this. Full bladder, that's easy. You put in a Foley. What are you gonna do if it's this one? If it's a full bowel?
Edema.
Well, you're gonna have to go in there. So glove up, lots of lube, and then get in there. Okay, you have to do a disimpaction, which is no, that's a job. So these are the other causes which I already mentioned. Here, lying or sitting on a hard object, which can include also your testicle, um, or any injury. So basically, these are extreme stimuli that cause either extreme pain or some strong stimulus. All right. So this is the UTI right here, the kidney infection. Um, so here, when you see that, when you see the signs and symptoms here, um, always consider possible autonomic dysreflexia. And the first thing you go for is what? What would you, the first thing you check? What's the most frequent cause again?
You check the bladder.
Okay, check the bladder. You guaranteed 99% of the time this thing is full. And of course, what you do first is, the first action really should be this one. I know this is listed first, and of course you check the blood pressure. That's why you recognize that it was autonomic dysreflexia. This one is not your first action. In fact, look at this. To reduce blood pressure if severe or sustained hypertension occurs. So that's not your first action. This is your first action. You put the patient in a sitting position. It will have to be higher than 45. I mean, 45 is not really sitting position. So that one drops the blood pressure until you can look for the cause. So again, what's the most frequent cause? The bladder. So if they have a poly, maybe it's kinked or blocked. If not, then put one in. And this is the other one, which you would pray that it's not that, because you know what you have to do if it's that. And these are, if these two check out, meaning you don't feel any bladder distension or you don't feel any stool here, then check for other stimuli. I mentioned pressure ulcers already. So any noxious stimulus again. Noxious meaning painful stimuli. This could be a tight clothing, some object, because remember these are paraplegics, so they have no idea what they're sitting on. All right, or maybe they have a UTI. Okay, and as far as this one, here's the pin site. That's why we do pin site care, because of course this is invasive. We have a screw um, lodged into the skull. So of course you can't really dress that properly, and this is how you care for it. You use a clean cotton tip. Although it says here clean, I would use a sterile one, um, and then use one separate one for each. You know, don't clean them all. We have 4 pin sites, so don't use the same thing on all 4. So use a separate one. Crusting is expected, so just wash that off with saline, and here we can use the ointments. Here is usually betadine ointment. Peroxide, I don't think they were, yeah, here, so you should not be used anymore. Some facilities use this, but it should be half strength only. If you have to use hydrogen peroxide, then it should only be half strength. And here's a safety alert about pin site loosening, because now your stabilization is now unstable, and that's dangerous. So make sure it's the screws are on tight, that the um, pin sites are not loose. Okay. And yes, we need pressure ulcer prevention and swallowing. It can be hard to swallow with that halo brace on. No, because you're in one position and you can't move your neck because that brace is in the way. So it can be difficult to swallow. I'm not testing the surgical management, so skip that. And that's about it. Here's your summary for your nursing care. Um, Again, two complications that are tested are neurogenic shock and autonomic dysreflexia. These two are life-threatening, therefore questions will be, do you recognize it? How do you recognize it? And then second is, of course, what do you do next? Again, emphasis on life-threatening, neurogenic shock, autonomic dysreflexia, equally fatal. That's definitely testable. That ends our class today. Any question?
Yes, Professor. So for next week in lab, are we going